Welcome to MenopauseWize, your go-to podcast for all things evidence-based in the menopauseverse. I am Dr. Sukhpreet Patel, an MD gynecologist, a menopause health advocate, a postmenopausal woman, and the founder of MenopauseWize. And I'm so excited to have you join us on this journey. Whether you're a healthcare provider looking to stay on top of the latest evidence-based practices, a woman navigating your own perimenopause or menopause journey, or a partner or family member eager to support a loved one, this series is designed with you in mind. Our mission through MenopauseWize is to close the menopause knowledge gap by bringing you the latest research, expert insights, and practical advice, empowering you to make informed decisions about menopause and perimenopause. Hello and welcome to the MenopauseWize Podcast on dense breasts and the diagnostic gap with Dr. Paula Gordon, a true pioneer in the field. Dr. Gordon is a breast radiologist and clinical professor at the University of British Columbia, Canada. She was a pioneer in the use of ultrasound in the breast, and her research was the first to show that ultrasound could find small cancers that were missed on mammograms in women with dense breasts. Because of her tireless advocacy, women across Canada are now informed whether they have dense breasts in their screening mammogram reports. And she and her colleagues have succeeded in persuading all the provinces to lower the screening mammography age to 40 years. And that, I think, is a really big win. Congratulations on that. And Dr. Gordon volunteers as medical advisor to densebreastcanada.ca and densebreast-info.org, and as vice president of the board of the Canucks for Kids Fund. So thank you so much for joining us today, Dr. Gordon. It is such a pleasure to have you here. I have been following your work for a while, and it's always been so nice to listen to you in that calm and composed way, still putting your point across, but not creating panic for women. I think you do such a great job at that. So thank you for that.
Thank you. Happy to be here.
So let's start right at the beginning, because I think a lot of women have heard or have been told they have dense breasts, but they may not understand what that really means. So if you could explain to our audience what the term breast density means, and what does it mean to a woman when she's told she has dense breasts?
Breast density is when we look at a mammogram and we see different shades of black and white, like on any x-ray. And on x-rays, fat looks black and other tissues look white. And unlike other parts of the body, like chests and bones and so on, where normal pretty much looks the same from one person to the next, a normal chest x-ray looks the same in a man, a woman, a child, breasts can look very different and all be normal. And women have different proportions of fat and breast tissue in their breasts. Some women, when you do their mammogram, the breast looks completely dark gray or black, and they have very little glandular tissue. And then some women have a little more, some women have quite a bit more white stuff. And then there are the women who have almost no fat and their breast looks completely white. And those are the four categories of breast density that radiologists all over the world use. And they're labeled A, B, C, and D. A is the completely fat. B has a little bit more fibroglandular tissue. C has yet more. And then D is the complete whiteout where there's no fat. And they're all normal. And about 40% of women over the age of 40 have dense breasts. It's normal. It's common. But there are consequences of having dense breasts, and that's what this is all about. For cancer to show up on a mammogram, all cancers are white. Now, other things are white too, non-cancerous lumps like cysts. But for any lump, including cancer, to show up on a mammogram, it's going to be white, and we can see it better if it's surrounded by black. It's like seeing a star in the sky, where, or for example, you can't see an individual tree in a forest from far away. Or the analogy we use a lot more is it's like seeing a snowball in a snowstorm. If a woman has normal but lots of dense breast tissue, there could be a lump there that we can't see on her mammogram. And so that's the number one risk, if I can use that word, of having dense breasts. The denser the breast, the harder it is to see cancer. And we call that the masking effect. There's another risk of having dense breasts, and that is that women with dense breasts are at a higher risk to get breast cancer than women with non-dense breasts. And the way we quantify that is we can say that women with the very densest breasts, the category D, are 4 to 6 times more likely to even get a cancer than women with no dense tissue or category A. Now that sounds like a significant increase in risk. What other people like to do is say, don't compare it to the people with the lowest breast density, let's compare it to average. And if average is categories B and C, we can see that women with the densest breasts are twice as likely than average to get a cancer. And women in category C, who also have dense breasts, but not the very densest category, they're about 1.5 times as likely to get a breast cancer than women with average. So the challenge is we want to find as many cancers as early as possible. And the double whammy for women with dense breasts, if you like that expression, is not only that are they more likely to get breast cancer, we're less likely to be able to see it on a mammogram. And so that brings in the subject of what can we do for women with dense breasts to give them an equal opportunity for early detection as women with non-dense breasts.
And I think what you said at the beginning was so important, that they may be dense breasts, but they are still normal. And I feel a lot of times there can be a misconception: does density correlate with the size of breast? Does density correlate with something that I'm doing? And yes, could you talk a little bit about, is there something that I can do or not do to contribute towards the density of my breasts? And does it change over the lifespan, especially the reproductive stages of a woman?
So younger women tend to have denser breasts, but not all women do. I've seen 25-year-olds who had category A, no dense tissue, and I've got loads of patients in their 80s with very dense breasts. So there is a continuum, but it doesn't apply in every single woman. And the only way that a woman can find out if she has dense breasts is on a mammogram. As you said, it is not related to breast size, and it's not even related to how the breast feels when on a clinical breast exam done by a physician, or even a woman doing her own breast self-exam. A fatty breast can feel solid like concrete, and a dense breast can feel soft and floppy, and everything in between. There's some women whose breasts feel like a bag of marbles, but that has no relation to whether she has dense breasts or not. The only way a woman can tell at the moment is with a mammogram. And there are hints we can get looking at ultrasounds and MRIs and other tests, but the gold standard for measuring breast density is the mammogram. And women now, as you said, can start having mammograms at age 40 in most jurisdictions in Canada. They've all pledged, even the ones who aren't there yet have pledged to get the age down to 40. For example, the most recent one was Alberta, and they said, okay, we're lowering it to 40, but not for another year. So they started by lowering it to 45, and now they've said they will lower it to 40, but it varies. And the way that women find out varies from province to territory and so on. Many women receive a report in the mail saying what their screening mammogram showed, whether it's normal or there's any abnormalities. And in many provinces, it also says your breast density category is A, B, C, or D. Other provinces don't send a letter. The patient has to know to look it up on her online portal where she can look up the result. I'm a little disappointed that British Columbia is switching from mailed reports to the online portal, because that's just an extra barrier. Somebody gets a letter and they open it, they can read it, they can put it somewhere. There are women who are not computer savvy, and logging in is, even if you are savvy, it's still multiple steps. You have to go to the health services, whatever that page is, and then you have to log into something else and give consent, and there's disclaimers. Anyway, I
tried that recently, and it wasn't easy. It wasn't simple. And I pride myself in the way I can deal with tech, but it wasn't simple.
So that's how women find out if they have dense breasts. Most provinces are putting in some information about dense breasts, like, oh, don't worry, it's normal. It doesn't mean you have cancer. I think those letters downplay the risks. Of course, they don't want everybody panicking, but I think they try to trivialize them, which is a bit worrisome. So that's why it's so wonderful that people like you are helping get the word out.
Thank you. And people like you. So thank you for that. But you mentioned something about statistics to compare it with the average, the risk of breast cancer, compare it with the average, and it still could be twice the risk. But that sometimes can make women anxious. Oh my God, does that mean I'm going to develop breast cancer? But could you clarify that for our audience? It doesn't mean that every woman with dense breasts will develop breast cancer, and it doesn't mean that a woman with low density won't.
Absolutely. And we know there are loads of risks associated with getting breast cancer, but they're all relative. For example, even women who have the breast cancer gene, even the women who have a 20% or up to an 80% lifetime risk of getting breast cancer, they may never get breast cancer. But it means women should be more vigilant and do what they can to reduce their risk. Now, stepping away from the dense breast issue for the moment, we know that women who are overweight, especially after menopause, have an increased risk of getting breast cancer, regardless of whether you have dense breasts. If you really want to minimize your risks, then try to get to a healthy body weight and stay there. That is also a good thing to do if you want to minimize your risk of heart attack and stroke and other cancers. We know that alcohol is a carcinogen. We know that the latest guidelines in Canada are that more than 2 drinks a week is risky. And I have so many women say to me, oh, I don't drink very much. I just have a glass of wine with dinner every night. That's not harmless. So it's not just breast density, it's what else can I do? Get to a healthy body weight, exercise regularly, minimize or even avoid alcohol, and so on. Now, coming to density, there's not much a woman can do if she has dense breasts. We know it changes with age for some women. We know that it increases during breastfeeding, and that will typically regress. But the big point is at menopause, and that's the period where anybody who is going to get reduced breast density, that's when it tends to happen. And it's most likely for women in category C, where they may see a big change. We know that taking hormones increases a woman's breast density. We're learning a lot more about hormones, and they're not as bad as they were said to be a few decades ago. But being on hormones is another risk. But at the end of the day, women have to do whatever they can to increase their quality of life. And if women need hormones to have that quality of life, then get to a healthy body weight and drink less alcohol and try to balance what you can with what you can't.
Absolutely, absolutely.
So if women do know that they have dense breasts, one thing that has gone out of fashion is do breast self-exams. I would hope that women can all access supplementary screening, which we'll talk about, but good old-fashioned breast self-examination, that's at the end of the day how women find their cancers when we don't find them on another test. And unless a woman is at higher than average risk because of other factors, she's only going to start having a mammogram at 40, but she can start doing breast exams at 20 and 30 and get to know what her normal texture is. So the term breast self-examination went out of fashion, and I blame the Canadian Task Force on Preventive Health Care for that. They no longer exist, by the way. And there was confusing data about breast self-exams, and they said, oh, women are just going to get anxious if they touch their breast and they feel lumpy. Well, I just told you it's normal to feel lumpy, and the best person to know whether there's a change, and this is what happened when they said don't do breast self-exams, they said women should be breast aware. Okay, what does that mean? And if they notice a change, they should see their healthcare provider. Well, how do you know if there's been a change if you don't know what your normal feels like? And since some women can feel soft and floppy, and suddenly any lump that shows up when they're used to not feeling one is significant. But if a woman ordinarily feels very lumpy, she's going to be better at knowing whether that's her normal lumpiness than a nurse practitioner or family doctor. Women doing breast exams are the experts in what their own normal is. And until women can all have supplementary screening with either ultrasound or MRI or some other modality, for heaven's sakes, do breast self-exam. Because when cancer's found, I call it an accidental breast self-exam. Woman's washing in the shower and suddenly notices a lump in her breast. What if she had done a periodic, not every single month, you don't have to be compulsive, but just once in a while, remember to check your breasts and get to just say, oh yeah, that's my usual. I don't feel anything different, and then put it aside till next time. If women are still menstruating, they should do that when they're just finishing their period, because women typically the lumpiness, the normal lumpiness is worse before the period. The lumps feel bigger, harder, and more sore. So wait till you're just finished your period and do your breast self-exam once in a while. So that's something that women with dense breasts can do. The other thing they can do, depending on where they live, and this is why we want supplementary screening to be more equitable, because it's hugely variable across the country, is they should try to get a supplemental exam. And in some provinces, in British Columbia, for example, let me just backtrack and talk about the different tests. The most sensitive tests, and this is not a competition, but the most sensitive tests are MRI and a relatively newer one called contrast-enhanced mammography. Those are tests where the woman has an intravenous and an injection is given that highlights blood vessels, and then a hot spot or a lighter spot will show up on the image of where there are abnormal vessels. And that's not always cancer, but it's a worrisome sign. And that's the most sensitive. Those are the two most. It's called vascular based because the dye is given intravenously. Imaging. Ultrasounds, much further down the list, but it's what we have in British Columbia. Women who are of not increased risk, not hereditary risk. So there's a hereditary cancer program in British Columbia where women can get tested for the breast cancer gene if they qualify, and not everybody does. Even if you have a mother and sister with breast cancer, that doesn't mean you're going to have the test. But women who are known to have the breast cancer gene or untested first degree relatives can sometimes have MRI once a year in addition to their mammogram. Women who are not at high risk, who are category C and D, are eligible to have an ultrasound exam. Unfortunately, there are not enough places that offer it. And I'd hope you come back to asking me, how can we fix that? And in other provinces, for example, in Ontario, they've announced that women who are in category D can choose to have either an MRI every 2 years or an ultrasound every year. Getting it is another story because, of course, access is very limited, and Canada has the fewest MRI machines per population of at least 10 or 15 other countries that I saw recently in a graph. So It sounds great. Let's go have a test with the intravenous. MRI is not a test that's well tolerated. You have to lie on your tummy with your breast hanging down into the coil. You're in the magnet, which is claustrophobic for many women. And women who have pacemakers and some other implants are ineligible. Even in 2 large studies where women were offered MRI for free and women were at high risk, 40% of them declined.
Really?
So it's not well tolerated. Now there's a new way of doing MRI that's called abbreviated MRI, where a typical standard MRI took 45 minutes in the magnet. There's a new way of doing it. You still need intravenous, but you're in the magnet for about 15 minutes, but that still will be intolerable for women with severe claustrophobia. So the other test I mentioned, contrast-enhanced mammography, feels like a regular mammogram. It's a mammogram machine. You're not in a magnet. The claustrophobia is not the issue. You still need intravenous, but the material that's used in MRI is called gadolinium. The material that's injected for a contrast mammography is the same one that's used in CT scans, and we used to use in older tests like intravenous pyelograms and so on. And it has a higher risk of a contrast reaction, which can be very mild, or it can be full-blown anaphylaxis and cardiac arrest. And they're rare, and contrast should only be given in a place where they have a crash cart and a team that can deal with a severe reaction. So it's not without its concerns. But for women who really need the most sensitive test, those are the 2 best. Ultrasound, as there's no ionizing radiation, patients lying relatively comfortably on a stretcher, either on her back or slightly turned to a side, with firm but not uncomfortable compression by the probe. And there's 2 ways of doing ultrasound. One is with the handheld probe, where the technologist moves the probe back and forth across the breast. And the newer one, it's not so new anymore, called automated breast ultrasound, where it's a very large 15 centimeter footprint probe, which is placed on the breast and the scanner moves inside the probe, getting multiple images. And then that big footprint probe is placed on the inner part, the outer part, and the center, and it creates thousands of images that then have to be reviewed afterwards. Two tests are often used interchangeably when they're being described, but they are quite different. And I'm a very much stronger proponent of handheld ultrasound. But to be done well, it has to be done by an expert who knows what they're looking for. So, for example, in our practice where we do breast ultrasound, we do handheld, and it's only our most experienced technologists that are allowed to do it. But then there's far fewer images for the radiologist to look at afterwards.
And when we're talking about, all of these tests that we're talking about, I just want to clarify here, we're talking about screening. We're talking about a population that we think are healthy. These are healthy women going for their routine screening. They haven't been diagnosed with a cancer. They don't have a history of cancer. We're basically using it as screening methods. And that, I think, is relevant here just because if I tell a healthy woman to get an MRI done for her breast, it then needs to be a solid reason why she needs to go for it and go through that discomfort, right?
Depending on the province, though, because you can tell her all you want. If that province, for example, Nova Scotia, does no supplementary screening for women with dense breasts, but they do have what's called a high-risk program. There's only two provinces that have high-risk programs, Ontario and Nova Scotia. And unlike British, so for a woman to be considered high-risk in BC, they only consider hereditary risk. But risk can be high even if the woman doesn't carry the gene. And there are online risk calculators. The one I would recommend, and women can just Google IBIS, IBIS, risk calculator. And it's just a few questions which she could check off. They will include breast density if she knows her breast density, and it will spit out what is this woman's risk of getting breast cancer in the next 10 years and over her lifetime. And if she's regarded as being at greater than, in Canada we use 25% lifetime risk, then she's high risk, whether she carries the gene or not. And in Ontario and Nova Scotia, she will have MRI. But in other provinces like BC, you're only considered high risk if you have hereditary risk. And in the US, they use 20% as the lifetime risk cutoff for high risk screening. The other thing to know about is that it's MRI, like you said, you can't just recommend it and she gets it. In the US, their recommendations for MRI are much more liberal. For example, once a woman's had breast cancer, if she has dense breasts, she's going to be offered an MRI every year. And if she's had breast cancer younger than age 50, even if she doesn't have dense breasts, she'll be offered an MRI. Because we know that these women, because they're at higher risk, we need to do more than just a mammogram for them. In Europe, they made the recommendation that all women in category D have MRI every 2 to 3 years, but no less often than every 4 years. Now, they make the recommendation, and not everyone's having it because there aren't enough MRI machines and there aren't enough personnel trained to use them. But this is showing you how far along the science has come that we have data to support these aggressive recommendations. And in British Columbia, where we do a lot of screening ultrasound, unfortunately not everywhere, our practice is the busiest with screening ultrasound. I did an audit of our data in 2022 over an 18-month period. We had done over 5,200 screening ultrasound exams, and we found 32 cancers. Now that's 6.1 per thousand. If you read the medical literature, it'll say that typically with handheld ultrasound, you'll find 3 or 4 cancers per thousand. So we're finding way more. In the US, where women are having their screening mammograms more and more with 3D mammography, we haven't even talked about that yet, there's fewer cancers to find on ultrasound because they're picking more of them up on their 3D mammograms, which they do annually. So this whole conversation is very geographically dependent. And in Canada, if women want to know what's available where they live, the two sites that they can look on are, one is densebreasts.ca and the other is .ca. And they will both list tables showing what's available in every province. And if I can get in a pitch here, the way we got where we got, you're too kind suggesting that I made such a difference, because you know that I first published in 1995. And the only thing that moved the needle was when women started advocating, not doctors, not experts. I always jokingly say the medical system doesn't listen to experts, but politicians listen to voters. It sounds silly, but that's the only way. And if women live in a province, and I get emails, people find me through Dense Breast Canada, what can I do to get a breast ultrasound in Manitoba? Unless women stand up and reach out to their elected representatives, nothing's going to change. There are lots of competing good causes for medical dollars. And right now, women with dense breasts are discriminated against because most of the time they're only offered mammogram. And unless they get together and raise their voices, it's not going to change. So there's my plea.
Yes, and I think to all those women out there, please definitely see how you can make a difference, because as a collective, we can do so much for each other and for ourselves. And I just want to reiterate the risk scoring, the website that you mentioned. That's the Tyra-Cuzick scoring, right? So I will share the link. Yes, I will share a link of that in the notes. Thank you for bringing that out. So each one of us can actually calculate our lifetime risk and our 10-year risk of breast cancer, depending on our own characteristics. So that's important. And the other couple of resources that you mentioned that I will share in the notes as well, about 3D mammograms or digital breast tomosynthesis. Can you tell us something about it, using that as opposed to using regular mammograms in women with dense breasts?
So women don't actually have a choice. None of our provincial or territorial screening programs use 3D. It has been Health Canada approved since 2012. It is known to increase cancer detection, and even better, it reduces false alarms. So those times women are called back and it turns out to be nothing, it can reduce those, but it's not been employed in screening programs, which is where it should be. Where we can use it is when women coming for diagnostic. So if a woman has a lump and she comes for a diagnostic or a woman has, in British Columbia, if a woman's had cancer, she doesn't go to the provincial screening program for follow-up. She has to get a requisition and come for diagnostic every year. And then we can use a tomosynthesis, the DBT, then at our discretion. It is more costly to perform. It takes twice as long to read. And that's probably one of the reasons that the screening programs aren't using it, because it would cost them more, not just in terms of the equipment, but the image files. Each picture gets a 2D, the regular, and the 3D, which is like a video. When you think of it, you're scrolling through the breast like you can on a CT scan or an MRI. And those files are huge, so it costs a lot to store them. We have to pay to store things now. Of course, we used to have bags full of X-ray films. Now we've got these digital folders, and the tomosynthesis files are enormous and they cost a lot to store. And then of course the radiologists I don't read screening anymore. That's a disclaimer. I don't have to disclose my conflict of interest. I don't read screening mammograms anymore. I barely read mammograms anymore. But the radiologists are justifiably going to want to be paid more to do examination that takes them twice as long. On the other hand, because there are fewer recalls, then there's less, they'll have to pay less for the diagnostic workups on those mammograms that were abnormal at screening. So there's a little bit of cost saving there at the end of the day.
But also looking at false positives, if you can explain what a false positive means to our audience.
The term false positive really means somebody told you have cancer when you don't. So saying false positive, you notice I didn't say that, I said false alarm. Right? It's one of my colleagues used the analogy of a smoke detector in your house. Sometimes the smoke detector goes off when you're cooking and too much. It's not a fire, but it's a false alarm. And you're happy to have that false alarm. And as soon as you realize it's not a fire, your anxiety goes away.
And how does one balance between a callback for a supplemental screening?
I just have to interrupt because you're using a whole bunch of expressions that are wrong.
Okay.
Now,
All right. Sorry.
okay, so a recall is there was something on your mammogram and we want to look at it again. And most often that's because we want to rule out cancer. Screening means
Mm,
the patient has no problems and she doesn't have any abnormality on her mammogram. Okay, so a normal mammogram and supplemental screening like ultrasound or MRI. When you're recalled from a screening mammogram, that's a diagnostic study. And I'll give you the numbers. And this is from our own provincial screening program. Every 1,000 screening mammograms we do, 70 women will be recalled. Believe me, each of them thinks,
wow.
okay, I'm one of the ones with cancer. 930 get a normal mammogram report. Now, some of them have dense breasts and maybe it isn't really normal, but anyway, 70 of them get recalled. Most of them just have another mammogram picture, maybe an ultrasound. Of the 70, 11 are told that they need a needle biopsy. And of those 11, 4 turn out to have cancer. Now, there are things on mammograms and even ultrasounds where cancer and non-cancer overlap. If you have a mass on your mammogram, we look at how smooth the edges are, or are they jaggedy and irregular? Same thing on an ultrasound. There are different features we look at the image which point us one way or another. If we're more than 98% sure, that's a real number, we have to be more than 98% sure that it's not cancer, then we don't recommend a biopsy. We say it's probably benign. And by probably, we mean less than 2%, not 50-50, probably benign. Let's look at it again in 6 months. And we're looking at it again to confirm what we already believe, that it's not going to change. It's nothing. It might be a cyst or a fibroadenoma. Actually, if we did the ultrasound, we'd already know if it was a cyst. But we just want to be more sure. If we're less than 98% sure, then we recommend a biopsy. So I could be 95% sure something's not cancer, but I'm still going to recommend the biopsy. And that makes women anxious, of course. But needle biopsies, they sound so scary. The freezing works like a dam. It stings, and not terribly, for about 15 seconds. And then after that, all the woman can feel is me pushing really hard with the probe to hold the lump still while I'm putting the needle into it. And women afterwards, I ask everybody, was that as bad as you were expecting? And list of favorite answers. The best one I had originally was a woman who said, Dr. Gordon, I have shoes that are more uncomfortable than that test. Another woman said, the worst part of this test was walking here in the rain. It's a little more glamorous than having a blood test from the arm, but it's really not much more uncomfortable. So that, do I want to put a woman through a little anxiety and a needle biopsy to be more sure she doesn't have cancer? Of course I do, because if I don't, and this is what the opponents of screening, including our disbanded Canadian task force, said. They said that the harms of screening outweigh the benefits. And the benefits are not only saving lives, but because when we find cancer early, women can be treated less aggressively. They can skip chemo sometimes. They can have a lumpectomy instead of mastectomy. They can avoid an axillary dissection and have permanent lymphedema. Those are the benefits. And what are the harms? The anxiety we put women through when they are recalled. That anxiety, as I hope I convinced you, is transient. And women can handle it better if somebody tells them, please tell them before they go for their first mammogram, don't panic if you get recalled. Because especially on a woman's first mammogram, when we don't have a prior to compare with, that's when the likelihood of recall is highest. And then as the years go on, and we've got these priors to compare with, she's less likely to be recalled. So you want to know that who the most anxious patients are? The ones where I'm doing a biopsy and they realize that they've got a cancer and it's big and it might even have spread to their armpit and it could have been found sooner. Those women are anxious. The transient anxiety we put women through when we recall them, women are horrified to hear that's why they're being denied a mammogram. Women should definitely be told about the possibility. I just said, please tell them. But our task force is saying, no, we shouldn't even screen them. And if we don't screen them, we lose the opportunity to find those cancers when they're early. The other harm that the task force cited was the concept of overdiagnosis. That's a little harder to explain. Overdiagnosis is when we find a real cancer. It's not a false alarm. We find a cancer, but then the woman dies of something else sooner than that cancer would have killed her. So what could that be? We find a cancer, the woman has her lumpectomy and is doing well, but then she gets pancreatic cancer and dies in 6 months. And that's far sooner than her cancer would have killed her. We don't know when we diagnose a cancer that she's going to get pancreatic cancer in the next few years. We don't know if she's going to have a heart attack or a stroke. We don't know if she's going to get in a car accident. All those things are competing causes of death, and they're real. But our task force, because they used a flawed study done in Canada in the 1980s, derived the likelihood of overdiagnosis as 48%. They're saying 40%, 8% of the cancers we're diagnosing are overdiagnosed. No. When you look at the studies that were done well, the incidence of overdiagnosis is 1 to 10%, and probably in the lower end of that range. And furthermore, because younger women are less likely to get other cancers and heart disease and stroke, using the excuse of overdiagnosis to not screen younger women is completely inappropriate. Diagnosis is vanishingly rare in young women, and young women are important to screen. When we're talking now, the fight we had to get a screening for women in the 40s,
Yes.
When women are still menstruating, they're making hormones, their cancers grow faster than an older woman. And women in their 40s nowadays, they're looking after toddlers at home, they're working, they're contributing to the economy, and they're looking after their aging parents. So these are not expendable women. And even though their cancer incidence is lower than in older women, cancer gets more common as you get older. And if you don't die of something else, it keeps going higher and higher, which is why women should keep getting screened after 74, which is another fight we're taking on.
Yes.
But younger women really deserve to have their cancers detected early.
That's I think such an important thing that you're talking about, starting early, because a lot of women even in the 40s are going through perimenopause. And I come from India. We do have a relatively lower incidence of breast cancer among South Asians, especially Indians. But it could be because we're not screening them soon enough. We've also seen a decade early occurrence of breast cancer in Indian women as compared to Western counterparts. But as women overall, we're all going through the same anxiety. Do I have breast cancer? Why have I been called back? And I want to go back to the recall. Firstly, thank you for correcting me. But at the same time, I feel the anxiety is not really for the recall. And you pointed out something really important here, that so as a doctor, I have some background. Oh, no, I've just been called back for an ultrasound. It's pretty routine and I shouldn't worry about it. And still for a few seconds, I had that blip, but it was gone within a few minutes. But I feel as if a woman isn't counseled about the numbers which you just brought out, what are we looking at? 98% certainty, and then you go for a biopsy. So I think those numbers, that counseling for a woman is so important. Just because you have this recall doesn't mean you have cancer. We just need to look closer, and that's so important. And that's what I keep listening to you on social media as well. I think that's such an important thing for women to understand, that it doesn't mean you have cancer. It just means you need a closer look, and that's one thing. But I think the anxiety also in Canada, especially. And I know it's an overburdened healthcare system, but it's the long wait that also makes one anxious. If I'm told I have a recall and I'll be seeing next week as opposed to I'll be seeing 3 months down the road, it's a burden to carry for a woman who's anxious. Could be anxious just because she's perimenopausal. So that's another story.
An explanation for that too. It didn't used to take this long, but there are not enough practitioners, fellowship trained. Even you can be a really good non-fellowship trained general radiologist who does breast interpretation, and it's not a good look for a radiologist to complain about income, because most radiologists do really well, but breast radiology is vastly underpaid. And radiologists finishing their training are choosing not to do breast. And you can't blame them. They've got student debt and they want to buy a house in an expensive location. and they're not going to take a job that pays them less than half of what they could get paid working somewhere else. And that's where we're at right now. So it's politics and it's finance, and we shouldn't even have to talk about that in medicine when we're talking saving lives. But that's the problem. And this again is where the patients, the women, need to, and it's not that hard. Anybody can phone their local, not municipal, don't municipal, but their provincial or federal elected representative as a constituent and make an appointment and go talk to them and say, here's what's happening. And I had to wait 3 months and it was torture. And then I had cancer discovered and I couldn't help wondering, was it spreading and growing in that 3-month period of time? The human stories make a huge difference, and women need to go to the effort. They have to take the time. And if they want, they could reach out through Dense Breast Canada, for example. When we started in British Columbia, the patient who was going to speak to her elected representative asked if I would come, and I did.
Wow.
Told a personal story, and I gave the scientific data. And then when we went provincially, it was an extraordinary and unique situation where I met with he was a minister in the provincial government at the time, and I told him what was going on, and he said, you need to speak to my colleague because she's had breast cancer. So I spoke to her, and I said, can I come and speak to all the women in your party and explain this? And she said, I'll do better than that. I'll hold a session where all the women elected representatives from all the parties can come and listen. And so the patient and I went, and she told her story and I told the story. And before we even finished, the women were talking to each other, and they ambushed the health minister and said, you got to fix this. So but it always starts with the patient. Yeah. And the elected representatives are the ones that can fix the problem. And yes, it has to go through the ministry and it goes through the bureaucrats and all that stuff, but it happens. And that's what we've done province by province. It's been very painstaking, but we have a long way to go on supplemental screening, and that's where women can help. Now, we haven't even talked about the older women because, of course, 70 is the new 50. Yeah. And most provincial screening programs stop at age 74. Now, why did they pick the number 74? Because if you look back to all the randomized controlled trials done between the 1960s and 1980s, that's when the trials stopped accruing women. So that's the group we have data on. But there's non-randomized trial data showing that you should keep screening beyond age 74 in women who are healthy with a life expectancy of at least 10 years. Now, the average life expectancy in Canada, and this is from Stats Canada, for a 75-year-old woman is 13 years. And for an 80-year-old woman, it's 10 years. So we should be screening at least till age 80. And I have patients that are like they're golfing and skiing in their 80s and they're still coming for mammograms. But it depends. If you've got lung cancer or end-stage kidney disease, don't come and have a breast mammogram, because chances are your kidney disease is going to get you before a breast cancer would. Yes. Yeah. But women should also be advocating. There are, I'm going to get my numbers mixed up. Right now, there are 7 provinces that let women come annually if they have category D breasts. Everybody should go annually, but that's not going to happen. But especially younger women whose cancers grow faster, women in the 40s ideally should be screened annually. I'll come back to what's my ideal list at the end. Remember, yes. To me. But women in I think it's 4 provinces can keep referring without a doctor's referral. They just have to phone the screening program, make their own appointment, and they can refer past 74. But all provinces and all women should have that ability, because the minute you need a requisition, it's a barrier. How many millions of women in the country don't have family doctors? And some of them, even if they get to their family doctor, they're being refused a requisition because their doctor is still following the old guidelines from the task force, even though the task force has been disbanded. Their website is still running. And unfortunately, the former members of the task force are still giving lectures to family doctors, telling them that they shouldn't be screening as much.
You mentioned every woman should have, actually, in an ideal world, have it annually, and we will come back to the ideal situation. But could you That brings me to interval cancers. And could you explain what an interval cancer is and what happens when we spread out screening over many
So
years?
we love to find cancers at screening. That's the
Mm.
earliest we can find them, when women can have the least aggressive therapy and the most likely to not die of breast cancer. If a woman isn't, if a woman's having, let's say she's in British Columbia, she's in her 40s, but she doesn't have a mother or sister with breast cancer. I should add that, by the way. Every province will allow a woman to come every year if she has a first degree relative, mother, sister, daughter, not aunt, not grandmother. But if she has a first degree relative, she can go annually. And that is the ideal. I'll take it one step further. The ideal would be if she could have a mammogram with tomosynthesis every year. But as I said, our provincial programs aren't using it. But if a woman's having a mammogram every 2 years, and let's say she has her mammogram at a time when the cancer is one day going to be visible, but it isn't visible yet. Let's say theoretically, 6 months later, a cancer would have been visible on a mammogram, but she had a negative mammogram and she has to wait 2 years till her next one. If she had her mammogram in 1 year, we would catch that cancer earlier. But because she can only have it every 2 years, you're giving that cancer another year to grow before we find it. And in young women with more rapidly growing cancers, that can mean the difference between it having spread to the armpit or not, or even spread elsewhere. There's some very high grade, rapidly growing cancers that spread very quickly. And by the time we find them, it's because they are having bone pain and they've got bone metastases, and it's tragic. So that's why everybody should have it annually. And we have data that shows that you save more lives if you do cancers annually from 40 to 74. But as I said, no province allows that.
But often when
sorry.
I'm talking to women, sorry, go ahead.
You asked me what's an interval cancer. I got off track.
Yes, yes,
Okay.
go ahead.
An interval cancer is one that's diagnosed after the woman's last mammogram was negative. So let's say the woman has a negative mammogram at age, it doesn't matter what age she is, she has a negative mammogram, and 8 months later she notices a lump in her breast and she gets it checked and it turns out to be a cancer. That's an interval cancer because it was diagnosed in the interval between planned mammograms. Whether she was going to have that mammogram a year or 2 years later, it's an interval cancer. And we look at those interval cancers because most of the time they are not visible. If you look, you know exactly where it is because when she showed up with the lump, you did the mammogram, you can see the cancer, and now you compare with the prior mammogram that was negative, and even knowing exactly where to look, the cancer wasn't there. So that's one kind of interval cancer. Another kind is you look back, and now that you know exactly where to look, there's something off that maybe you could have called back, but you didn't because it's so low conspicuity. And so those happen as well. And by doing the mammograms more often, those really not suspicious things a year later might be actionable. They might have changed to the point that you do want to call the patient back, doing supplemental screening. And it's interesting. So when I did the audit of our cancers discovered at screening ultrasound, because we recommend that the ultrasounds be done halfway between planned mammograms. So if a woman's having her mammogram every 2 years, we want her to have that ultrasound a year after her mammogram. If she's having a mammogram every year, then it'll be 6 months after her mammogram. So we're alternating mammogram, ultrasound, and so on. When we find something suspicious on a screening ultrasound, and we don't see it on her previous mammogram, her screening mammogram was negative, we'd sometimes, depending on the radiologist and how far away from the mammogram that suspicious finding is seen, we'll repeat the mammogram. And because it's not screening anymore, we can do tomosynthesis. It's interesting how often the mammogram is still negative if you look at that 2D. But when you have tomosynthesis, the DBT, there is some speculation that didn't show on her 2D. Remember, I said 3D mammograms find more cancers. They find them because a 2D mammogram, the breast is compressed, the x-rays go in, they come out the other side, and nowadays instead of film, it's a digital detector and it makes the picture. What the tomosynthesis does is it breaks it down into multiple slices. and you have your 2D picture, but then you can scroll through in slices. So you might find a slice where there was a little bit more fat in that part of the breast, and lo and behold, that fat is outlining something irregular. So the interval cancers, as I said, sometimes they're visible in retrospect, but typically very subtle, or sometimes they're even know exactly where to look. And even using a 3D mammogram, you can't see them at the time that her cancer is discovered. So that's what an interval cancer is. And we know that interval cancers are 13 to 18 times more likely in women with dense breasts. So that's another reason they need to have supplemental screening. And they should be having mammograms more often. 7 provinces recall women annually if they have category D, but the rest don't.
That was going to be my next question. Are internal cancers more common in women with dense breasts? But coming back to annual screening, if it was possible, the question that I get asked very often is, and the concern actually from women is, oh my God, that's radiation. And I've heard that getting mammograms increases your risk of cancer. So could you just give us a one line on the radiation exposure? Yes.
Absolutely. There's 2 things women are afraid of. They're afraid of radiation and they're afraid of pain. And they've heard horror stories about the compression. Let's do the compression first. The breast is compressed and it should be uncomfortable, but it's for a few seconds. It should not be excruciating. And women should not be shy to tell the technologist, I'll tell you when to stop. I'll take as much as I can, but I'll tell you when to stop. And when I say stop, you have to stop. Okay? And especially if a woman's had a mammogram before that was painful and is reluctant to go back, if I get a chance to talk to them, I say, this time, don't just suffer. Tell the tech even before she starts positioning you that last time was a nightmare and you got talked into coming back, but that you will tell her when to stop. That's okay. So the compression is one thing women are afraid of. The radiation used for mammography is very low, and it theoretically might cause, it's something like 1 cancer in 100,000 mammograms. I forget what the number is, but the other analogy is that women need to know that we are all exposed to radiation every day. It comes from the ground, the air, and the water. And the radiation you get from a mammogram is the same radiation you'd get living at sea level for 7 weeks.
Yeah.
If you live at elevation, because radiation's higher, the higher up you go, it's the same radiation that you get living in Denver for 3 weeks, or the same radiation that you'd get doing 1 transcontinental flight from New York to LA.
Wow.
Okay, so
that's a great comparison. Yes.
And given that it can save your life, the ratio of risk to benefit, the mammogram's a good bet.
Definitely. That's a good one. That's a good way to look at it. And I feel a lot of us want to skip the mammogram, want to avoid the pain, want to avoid the discomfort, avoid the diagnosis. And it's such an easy way to say, oh, it's just radiation, I don't want to have it. Or then say, I'll just get an ultrasound and I won't get a mammogram.
You can't have an ultrasound in BC anyway, and have it paid for unless you've had a mammogram and you have dense breasts and you have a requisition. And as I'm a big fan of ultrasound, obviously, but everybody should have their mammogram. Look at the women fighting to have access to mammograms. Isn't it a shame that there are women who are saying, I'm not going to go because of the radiation? Even in British Columbia, where women have been able to self-refer since age 40, since 1988, we don't have much more than about a 25% participation rate. And Ontario lowered the age to 40, I think it was October 2024, and they're only around a 30% participation rate. So here we have a test, and even the women who can access it aren't going. So women really need to understand that there's a lot of science behind this. There was a big study done across Canada that showed that women in the 40s who have mammograms are 44% less likely to die of breast cancer than women who don't. And even though the treatment's getting better and certainly the drugs are getting better, especially for advanced cancers, when breast cancer is caught at stage 0 or 1, the 5-year survival is virtually 100%. Even with all the fancy drugs and treatments that we have now, when it's diagnosed at stage 4, the survival's about 30%, 33%. And 65% of women are diagnosed at stage 0 to 1. And about 6% are diagnosed, they're already stage 4.
That is so reassuring.
Yeah.
Yeah, and motivating to get screened. So let's come to the ideal world. In an ideal world, what would you like to our listeners who've been engaged in this conversation, what is the ideal that you would like to put across to women listening to us just now?
Ideally, women should have a risk assessment by age 25 or 30. They can do that on IBIS themselves. Women should start doing breast self-examination, 25 or 30. Women who are at high risk should access whatever high risk programs are available to them. Average risk women should start having mammograms ideally with tomosynthesis, but that's not in the near future. Ideally, women would have annual mammograms at least until after menopause. Better yet, for the rest of their lives. But if they really don't want to go every year and they're not at increased risk and they do their risk assessment, then a mammogram every 1 to 2 years after menopause. And women with dense breasts everybody should do breast self-exam, but women with dense breasts especially, and they should access supplemental screening, either ultrasound or vascular-based like MRI or contrast mammography, depending on their level of risk. And women should keep having mammograms as long as their life expectancy is at least 10 years. I think I remembered everything.
That's very well summarized. I think you've covered all the entire range of reproductive stages. Women who fall into any one of these categories, they can either use it themselves, share it with their mother, with their aunts, with their daughters, with their nieces. I think you've covered women of all ages. So that's amazing. Dr. Gordon, is there anything else that I've left out that you'd like to put across for women with dense breasts particularly?
Just to take the time to reach out to their elected representatives. That's the only way things are going to get better. If they want some help, they can go to the Dense Breast Canada website and contact Jenny Dale, who's the founder and executive director, and she can probably introduce them to other prospective advocates in their provinces. We need more, as you say, groups, and Jenny is the master coordinator of that.
Yes. So thank you for that. And so thank you for this conversation. Thank you for your advocacy, and for women who want to do something about it. Please, let's do something about it. And if you're in Canada, please reach out to Dense Breast Canada. They have a handle on Instagram as well, or densebreastcanada.ca. Is that the website? Yes.
Yes, and it is dense breasts with an S on breast.
Oh, yes, dense breasts.
Okay.
I'll spell that out in the notes. So thank you once again for this conversation.
My pleasure. Thanks for having me.
Thanks again for tuning in to MenopauseWize. Stay informed, stay empowered, and I'll see you in the next episode as we continue to navigate the menopause journey together. If you're a healthcare provider interested in collaborating with us or have insights to share, we'd love to hear from you. Please email us at info@menopausewize.com. That's wise with a Z. And before we go, a quick medical disclaimer. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. Always consult your physician or a qualified healthcare provider before making any decisions regarding your health or any medical treatments discussed in this podcast. While we strive to provide accurate and up-to-date information, this podcast does not replace professional medical consultation, diagnosis, or treatment. If you have any concerns or symptoms that require medical attention, please seek advice from your healthcare provider.